everyone. Welcome to today's OR Manager webinar, How to Reduce Your Operating Room Supply Costs by $1 million and Increase Service Line Profitability by 15%, presented by Vi Healthcare. I'm Carrie Shapiro with OR Manager, and I'd like to welcome the attendees and thank our sponsor, Vi Healthcare. Before we get started, I have a few housekeeping comments. Today's session is being recorded and will be available on demand in the OR Manager store. We will take questions at the end of the discussion, and we encourage you to submit your questions in the Q&A tab section on your screen. Your questions will only be viewable by the presenters. If you experience any technical difficulties, please use the chat feature and a webinar technician will come online to help you. And today you will earn 1 CE after attending this webinar and completing the quiz that will be available in your OR Manager account. I would now like to introduce our speakers for today's webinar. Lisa Miller, founder and CEO of Vi Healthcare, is a proven cost reduction strategist and a recognized leader in healthcare performance improvement. Since founding Vi in 1999, Lisa and her team have generated over $757 million in non-labor cost savings and revenue improvements for her clients. Lisa specializes in operating room costs and profitability and has developed programs for clinical and physician cost awareness. Richard Dormer serves as COO Healthcare Margin Improvement Expert. In this role, Rich identifies and implements dramatic cost savings for Vi's clients. He has extensive experience and knowledge of hospital expenses across the organization and is passionate about helping guide Vi's clients to rapidly achieve their financial goals. Rich has led some of the largest healthcare organizations in their OR's cost savings initiatives. It is now my pleasure to turn it over to Lisa Miller to get started with today's presentation. Lisa?
Great. Thank you, Carrie, and welcome everyone. We're excited to have this presentation, and we have a jam-packed event. So I just want to begin that this presentation is copyrighted material. So if you're a hospital employee or a health system and you want this deck, please email me. I will gladly send this out to you. So if you work for a hospital, an employee, please reach out to me. I will send this deck. All right, let's start. Just a quick overview, but we've been working with hospitals since 1999, and we've had the privilege of supporting hundreds of cost savings initiatives in the OR and other parts of the hospital, and we're located here in New Jersey. And you're welcome to go on to our website. We've got a number of different research reports, 2 of them that probably are pertaining to what we're talking about today, which is cost reduction in the OR and then physician cost awareness. And so that leads us to where we all are coming out of, or still kind of a little bit within COVID, and really the need to look for cost savings, having this culture of cost awareness, looking at everything carefully and implementing a cost-saving strategy is so important. And everyone on this call working in the OR or surgical center, this is probably one of the most foundational parts of a hospital. Really, it's a cornerstone of a hospital's finance. And so today we're going to speak about a number of different areas in the OR, and specifically how to map out this $1 million and profitability of 15%, and just looking at different aspects. As everyone knows, the OR is a very complex environment. There's just lots of areas, and for those of you who've sent questions, we've weaved some of these in the presentation and also have them at the end. If we don't answer your question, please submit it in the chat box, and we will get those answered. I just want to start today. There's a great book called Think Again. I encourage everyone to read it. It really challenges us about our thinking and how to rethink certain things. And so I'm probably going to talk a little bit about things that maybe that are in that mindset of rethinking. And in the book opens up with a comparison of Steve Jobs and Apple and the CEO of BlackBerry, Mike Larteris. And it's interesting because, as everyone knows, BlackBerry is no longer here because he kind of really, buckled down and said, listen, this BlackBerry is going to stay and I'm not going to make changes. And it was interesting, we all think that Steve Jobs made this brilliant decision about the iPhone, but in fact, he never wanted to have a phone and the music. It was really people on his team that kept on pushing him. He did not want to get involved with a wireless provider. And finally, he said, listen, just go play with that and figure it out and come back to me. I'm willing to rethink it. And so we know now today what's happened with the iPhone. And I just encourage everyone to be open-minded in everything, even our presentation, because rethinking is really an important part of all our daily jobs. So I will start off by talking about, particularly in the OR, we have a lot of costs that require direct agreements with the vendors. And, GPOs are an important part of our ecosystem, but they, in many times, are just a starting point, particularly in the OR. And I am going to really push on this fact of pricing is important, or the analysis of costs are important, of total case costs, because there's this constant, pushing back and forth with vendors on different aspects of cost. Even, for instance, for total needs using a revision component in a primary case, and that increases that cost. You don't get more reimbursement for that. And so this goal of hospitals really learning to source for themselves beyond the GPO and having advanced negotiation analytic skills is so important. And the other, this is only a snapshot of all the procedures in the OR, but it is this trend that we're seeing, particularly around joint replacement. And the biggest insight into what I'll be showing you as a kind of lead up into some of our work is that there's such a variance in pricing. We've made tremendous progress. Hospitals across the country are working on their orthopedic, their spine, their CRM costs. But what we still see is that there is this variance. And, you may have, just redone an agreement or looked at cost or analyzed your surgical line profitability, but we encourage you to do that every 6 months or every year because this gap or this difference we do see in the marketplace. So here are the 7 areas that this presentation has been weaved in and out of, but it's really core to cost and profitability. One is contracting and pricing opportunities. As I said earlier, the ability to have direct and strategic contracting with your vendors. 2, mapping cost to actual reimbursement, not average, not expected. This actual reimbursement is actually a key nuance, and there may be a 30 or 60-day lag, but getting real reimbursement and getting that reimbursement by rev code detail and mapping it to your cost is actually probably the single most important aspect, because you're going to pinpoint and see things in that analysis that you wouldn't see, and there's some really interesting analytics that Rich is going to speak about in a moment. Inventory management, we all kind of struggle with the owned and consignment inventories of items, reduction of waste or elimination of waste. I love number 5. There's an interesting study that came out just showing physicians their consignment inventories of items, reduction of waste or elimination of waste. Sorry, there was a little feedback. So number 5 was it's one of the areas that I love the most is, a physician cost awareness, because just showing physicians where their costs are and not asking them to be part of the negotiation or change, just giving them that insight shows, there is a reduction when they become more aware. And there's all these different kinds of programs around physician cost awareness. Number 6, we all know standardization is key, but how do you do that? What's the best way to do that? And 7 is preference cards. We're going to, I'm going to cover these quickly. There's a lot on here. Again, if you're, work for a hospital, we will send these slides to you. But there are these 6 components that are really, really key, and they are getting the price right. It is absolutely certain that you are paying the right price, you get the right utilization, you're systematizing your data and spend analytics, you have a culture of cost awareness has a curiosity about cost, adoption of cost innovation, and of course a discipline of cost management. Sometimes we focus so much on the executing of the agreement, and then that agreement doesn't have a way or a process that you're managing this on a monthly basis. How do you look at costs by DRG, by month, by position, and not high level? You need the details. The dollars are in the details. Those opportunities are there, and you can't have an aggregate number. You've really got to have a way and approach to manage your costs. Recently, I did a video and a blog post about these areas of how vendors keep their margins, increase their margins. And the reason why I bring this to your attention is because every single day, everybody on this call, if you work for a hospital, you're negotiating in some way, shape, or form with a vendor. And we work with hospitals and helping them really advance their negotiation skills and really bring to light some of those strategies and tactics that can be used or are being used with them at their hospital. But these are things that we see that really have to pay attention to. And one is the vendors are changing their list price book every year. So your 2021 list price book will probably look very different than your 2016 price book. And that matters because if you have a 30% discount both years and your 2021 list price book has increased by 35%, I mean, you see that problem in that. So it's really important to have and maintain those list price books, and also a policy or in place that really minimizes this. Obviously, there is room for reasonable CPI increases, but we see that, number one, it's become tremendously unreasonable. You'll hear a lot about internal pricing committees, and that's a way to really stretch out and pull out the time frame, or create obstacles or challenges. You have complex pricing structures, so you've got tiers in order to get to the next pricing level, and that becomes very challenging for hospitals to manage, or even a lot of times there's some inaccuracies as that's being performed over the years. Utilizing your GPO's access pricing. Many times the access pricing is a very underperforming price, and you've got to go well beyond that access price and really pay attention to understand what kind of tier is this, and really, if this is a preference item, we should be direct contracting or doing something a lot more strategic. Rebates, and we're seeing a lot more use of rebates, and also a lot more hospitals are pushing back on the rebates, which we love. It's really pushing back this, we need this invoice price. And then, of course, number 6 is introducing the same product but making a minor enhancement and really representing it at a 25 to 30% higher cost. And so, these different changes doesn't require that amount of increase. However, and also the hospital doesn't get paid more money, doesn't get more, the reimbursement doesn't change, and that has to be the narrative back, that your payment structure doesn't change, and of course having a value analysis and the physician engagement is so key to these conversations. So as I said earlier, this is something that we talk a lot about for our clients. That contracts can prove to be a great benefit for organization, but most focus on the front end, and this is great. You can get a great contract, great pricing, great total cost. However, many times it's not looked at again until renewal. And this is a research done by a purchasing organization, and they came to the conclusion that it's about 9% of a total revenue is lost because there isn't a formalized way to manage a contract, and that's not into a contract management system. This is an active way to have a monthly view on your OR spend. And it's, more than by surgical alignments, really drilling down into those high-cost implants and connecting them into those components in a case. It is maybe a little more effort on the front end to create this, but once it's created, you will reap rewards, cost savings, but also protecting your costs. So you're not finding these issues out at renewal, you're finding them out as they're happening. You can address them proactively. There's a study, and we're going to go through some of these slides quickly. There's a study done about cost variations by Blue Cross Blue Shield. And they're the insurance providers. They get so much data. In fact, they're probably one of the best sources of data because they're getting the information, and they get it a number of different ways from their hospitals. But what the synthesis of the data is, there's a wide variation in cost. And again, I'm going to go through this quickly, but I'll show you this for a moment, and you can see that for for this implant, the various costs, whether it's greater than 17,000, down to 4,000. Again, they're mapping these cost variations, and they'll show you the highest versus the lowest. And yes, some of this is due to a markup. We understand that. However, a large part of it, because a lot of these contracts are based on trailer claims, they are measuring they are seeing the implant cost directly that's from the vendors the hospital is paying. So a lot of this cost, while it does have an element of markup, has a big element of seeing directly what these implant costs are for the hospital. And I think soon you'll find, if not already happening to some hospitals, is that there's going to be a bigger pushback on really capping even what is paid out on these implants, not the case rate, but even the implant cost, because they do see so much variation. So joint implants have skyrocketed in over a decade. Literally the list price have grown nearly 300%. Researchers found that up to 50% of variation in implant costs is related to hospitals' purchasing approach and its specific characteristics. So this includes vendor negotiations, relationships with surgeons, and other factors. Again, this is third-party research, and in the ability for a hospital to really take a, whether it's strategic approach, and that approach is bringing the physicians in, really being skilled negotiators. I encourage everybody, go take a negotiation class. Take an advanced negotiation course. There's so many those opportunities out there, but you'll learn a lot of the ways that you can really combat those challenges that you're being faced with today. So I'm going to turn it over to Rich for a couple of minutes as we talk about surgical case spend analytics and really looking at implant total cost analysis. So this is not just looking at maybe all the knee components, which is important, but maybe looking outside of those into the cement and the blades and all the other components that may, that are in that specific case. But it's really taking this total cost analysis view that will provide you with the opportunity to drive down cases. Okay, Rich.
All right, great. Thank you, Lisa. And really, I think this is a big piece that a lot of people miss or only get a little bit of the full picture. So, like you said, the total cost of the case, which obviously the implants is super important. But like Lisa said, the cement, the ports, other types of things, and sometimes it's brought into the case and it's on a bill only. Other times it's stock. So you're looking at stocked, non-stocked items, and how does that fit into, from a utilization and understanding actually the cost per case. The different types of instruments based on the vendor or the approach. Biologics obviously is a big factor in spine operations, but sometimes the vendor has their own. Sometimes they're brought in. Sometimes they're using again a stock. So there's different sizes, depending on what type of procedure it is. Now, second bullet point here is now market trends. Obviously, the latest and greatest, or what is the new technique, but also, and I'm sure a lot of people listening today, have seen this as well, is the representative movement, right? So we've all seen the case where the physician doesn't want to use a specific vendor, but all of a sudden their rep moves to that vendor and now they're utilizing it. So understanding those little frontline market trends as well is super important. And then really, again, that focus, total joint, spine, high-cost surgical cases, those are continuously reviewed, continuously looked at, understanding the cost per case on a cyclical standpoint, so we don't miss anything. And then, obviously, additional areas of targeted approaches. So we look on, the differentiation, right? And this is back to kind of how the vendors are changing, continuously changing the game. So they'll continue to innovate their products, which is great, but a lot of times it's really a slight evolution, right? So the question's always, is this an evolution or a revolution? So if it's an evolutionary change, then pricing should remain the same. But if it's a revolutionary change, then it needs to be put into a category and understood, right? So an example of some things that vendors have put into their cases, and I'm sure, again, a lot of people on the webinar have heard, but like the vitamin E liners, right? It added 40% to total joint cases. It's the same with ceramic hip heads, advanced coatings, right? There's also poly material that's inside the total joint cases and implants, as well as titanium, which they blend into the spinal components to add cost to it. Again, just another call, I mentioned it before, is just the techniques, the extreme angle spine screws, which we in some cases we've seen 100% markup or premium to the recently or the previously negotiated screws. Total joints, we talked about. There's also cutting guides where, obviously there's a picture of the knee and then they use a guide, which in some cases brings $600 to $1,000 per case. And we look at the components and the varying types of, when we look at trying to analyze and compare different vendors, we would understand what makes the components up within the construct, right? So, from a lumbar pedicle screw system, typically it's 4 screws, 4 caps, and 2 rods. But there are vendors that have 2-part heads, so it's actually, additional components that make up and sometimes often missed. When we look at some of the IVFs or interbody fusion devices or the cages, typically the cages have a lumbar fusion to fuse into the spinal, but they're also standalone IVFs, so they have their own integrated screws. But, give examples here where, Medtronic has two types. One has 2 plates and 2 screws. One has 1 device and 3 screws. And then we have some others that have a cage, a plate, and 4 screws, and one has, the IVF and 2 plates. So it really makes sure that we understand what we're comparing because, at the end of the day, one could be more costly than the other, even though they're exactly the identical products. Obviously we've seen in the OR the pacemakers through our CRM products, neuromodulation, urinary, women's health, drug-eluting stents, bare metal stents. These are all areas of focus that continuously have opportunities for pricing.
Yes, and somebody mentioned that the vitamin E lining, I think, had significantly improved outcomes. And yes, we agree that outcomes absolutely matter and are part of our analysis. But what we are also concerned with is that the cost can't exceed so much so in that, and really the hospitals having the ability to say, okay, there is, we're validating that this may have a different length of stay, or maybe there's cost savings further down the road. However, it can't be at such a premium. There has to be some give and take. So we do absolutely agree that these outcomes are impacted. They're important. They need to be put together and analyzed based on a complete picture, right? There needs to be a balance for hospitals. At the end of the day, the hospitals take on a big burden, and the ORs in particular, of these costs. So you've got to be able to say, yes, it has tremendous outcomes, and yes, we're willing to pay a bit of a premium, but what is that premium? What is the fair amount of that a premium should be? Okay. We're going to talk a little bit about mapping your cases surgical cases to the managed care agreements. Many of your cases are, of course, Medicare. Medicare is the primary payer, and you'll see further on some analysis that we perform and we encourage our hospitals to perform to analyzing their spend or the surgical line profitability, but by physician, but also by payer, because by payer gives you a completely different view. And again, this is done with actual reimbursements. But what we want to bring to everyone's attention is some of your contracts, you have trailer claims. And these trailer claim requests, you're probably getting them for actual invoices, have to be followed up on in order to maximize or really optimize your reimbursement. And so a managed care contract will specifically outline that the implants and devices, Rev codes 275 or 278, they have conditions and terms in order to pay for those. And one of the things that we speak a lot about is, it's important in the OR to get your managed care agreements, to really understand those nuances so that you can support finance. I mean, this is really a collaborative approach to the supply chain and finance departments, in the OR, because we have seen many times that some of these outliers, these trailer claims, aren't being submitted, and there's a reason why the profitability by cases are lower. And in fact, we've had to work with hospitals to get that redone or reestablished or put a system in place so those trailer claims can be submitted and it's done quickly and within ensuring that all of the parts of those implants are captured, so not just maybe the hardware, the biologics, or all the things and the conditions that the agreement promises can be submitted. There's another challenge that we all face, right? And it's bill only. And I want to bring that to everyone's attention because there are different ways to manage the bill only. But when you're doing an analysis in the OR, while we recommend that PO data reports, we recommend reimbursement data, we also recommend that you actually go through your bill only. It is manual. We use an extraction tool to support us to extract getting that in a quick way, and you can inquire with us if you're interested. But this is important because I can't tell you how many times that we've seen different pricing, different information, or just a different view on a bill only than you would see just running a PO detail report. That's why it's not the best scenario to take a PO detail report and just have that benchmark, because you need to see it in its total complete picture. So we're big supporters of taking this bill-only data, and if need be, taking 3, 4, 5, 6 months of that data and analyzing it as a total case cost. And sometimes there's a few different of those bill-onlys that map to one case. And now we're going to go into a section where we're really going to kind of dive a bit deeper into analysis and why we say we want to go beyond best-in-class benchmarking. We really want to look at all the different ways that you can look at, for cost savings or cost optimization. And so, this is just, to get us started a little bit. Again, what we see in the marketplace is variation. And that variation may be small, hospital B to C, you have the 4,600 to the 4,900, but look at hospital A, same components. And I bring this to everyone's attention. You'll see a couple of these slides, is that, $300, $400, $500 per case adds up. And when we look at surgical line profitability, we're looking at optimizing as many different components as possible or areas. And so, we see this every single day. Again, another analysis, right? Vendor A, vendor B. Similarly, one hospital with 4 different vendors, and look at the variation in pricing from $6,000 to double. And also with a lumbar pedicle screw system, and we see this quite commonly with variation. And so, I don't know if anyone's brought it up. I haven't looked at chat box in a minute, but you know, I know that there is a lot of conversations around utilization, like market share and volume. And so our approach is an all-play approach. The vendors all should be paying the same price for their implants. There shouldn't be that variation unless you're really going to go to a one vendor policy. But we work with hospitals and physicians all over the country, and it's all play. This is the pricing, and you know, hospitals, the physicians get to utilize what they want to utilize, but this is the price point, and there's no reason why one vendor should charge more for the same set of components.
The next few slides are really when you put the data together for presentations, either for physicians, clinical leaders, supply chain, finance, and really just making sure that first and foremost, the data is accurate, and then what you're trying to present. So, you know, just quick, this is a two vendor total joints, the total spend and the opportunity. And then what we do is we put together a side-by-side construct analysis, and you can see here that, you know, vendor A has, you know, a total joint, total knee that is $8,400, right? And then we have another one that's $5,500. And you would think, okay, so vendor A is most likely going to be the, you know, obviously the less volume, but in actuality, they were 72% of the market share. So they had the higher volume, yet they were the higher cost, and was comparable to knee. Same thing with the next slide with the hip. You can see that, you know, the difference between vendor A, which was at $12,000 and change, versus $8,900, yet, you know, from a hip standpoint, they're 41% higher, yet still, again, with their market share, they should have been better pricing. So even with better volumes, you're not always getting the better price. That's why it's important to match it up appropriately. This is a vendor that was with on the trauma side, but, you know, we want to do presentable presentations, right, for, again, for those groups that you want to have buy-in, and it's important. So this is a nail construct, and, you know, just from a benchmark standpoint, it was only the one vendor for this, but it was 37% opportunity. Again, vendor didn't, and you'll see in the next slide, which had 80% market share, yet, you know, had only a little bit of a discount. So understanding, you know, what that discount is and where the actual pricing compared to others, and like Lisa mentioned before, you know, the vendor's list price go up every year, and therefore their pricing goes up every year, but really, what is that competitive price? And it's super important to continuously review that, you know, and then what do the vendors do in the trauma? You know, foot and ankle, hand and elbow, which really should be excluded, are sometimes bundled in there as well. So there's a lot of different nuances within the trauma section that are important to be able to map out. You know, and we always want to make sure that, you know, from a strategy, we have the physician engagement, and then the strategy over vendor negotiations, and then really we talk about contracting, we talk about good pricing, but we want to make sure we have good solid terms as well in the agreements. And then what is the big value, and to, like Lisa mentioned before, you know, managing those contracts and making sure that things are being invoiced correctly, that are being, you know, there's no off contract pricing, there's no list price or things that, you know, are incorrect. So there needs to be continuous audits of the spend, and we usually say that should be done monthly, but a lot of times you don't have time for that. So at least semi-annually, annually, there needs to be reviews of past invoicing for accuracy.
Great. So we had a question about OR time, and that OR time question probably could be a separate webinar, but I would like to address it a little bit here. We do think it's very important to measure OR time in prime time utilization, and to really understand, you know, what this is a higher level overview of an assessment, part of an assessment that we had performed, but really looking at available prime time versus used prime time, and being able to, of course, break this down by room, by physician, by service line. I think the question was, you know, the value of that, and you know, in correlation with residents. And so, you know, I'm going to address that question in more detail later, but the best way to have visibility is to have a structure, right? And I think the first structure is the comparison of what's available versus what's used, and of course, measuring time, and then comparing time by similar case, and being able to do that, across different areas in the OR, across different positions, and you're going to see those variations. And yeah, it might be a sensitive conversation, but OR time is incredibly valuable, and it's important of what you're scheduling, and it's an important focus. But we begin to measure it, versus available and used, and then we continue to break down that analysis even further. So you could reach out to me. We have additional slides I can send you just specifically as it relates to OR time. One of the other areas that, is part of our capturing this $1 million in profitability is understanding non-catalog items. And we're going to go into a little, switch gears a little bit and look at, waste. We're going to look at other areas of optimization. But I will tell you that you have a gold mine of information in your PO data for the OR. Somebody should be mining that PO data weekly, monthly, looking at that data, having the different custom reports that's specific to your hospital, and mining opportunities. And it's so important. You could probably really have a tremendous work plan just from your OR PO data. So this is one example of non-catalog items in the PO data, measured by month, and then frequency of reoccurrence. So 2 months, 3 to 5, 6 to 8, 9 plus months. So a lot of things can be found mapping PO data and really looking at your stock. In this case, too much inventory, right? Understanding what's on your shelf versus what's being utilized. And in this case, we can see that the utilization is very low. However, there's a tremendous amount of stock. Yes, some of it could be consignment. Most cases there's a mixture of both, but why would you still want to carry a tremendous amount of consignment, that risk at your hospital? And I think mapping your PO data, your utilization data to what's on your shelf is key. We see this very frequently, particularly in the trauma area, but really in a lot of different cases, it's just items that are no longer, whether they're outdated, unused, they're in a corner. I put the slide in is that, sometimes it could be a small box, but this small box was worth over $400,000. And, it's really important that, there's a two-step process. There's one-step process to see if any of these boxes exist in your OR, and then taking those out and getting them returned, maybe not at the same price. We say yes, same price paid. That requires going back to your PO data. But really getting these returned at some point, making that in of itself a separate work plan. Because, that's just money you could recoup right now. The other area is sutures. We all know this, that sutures is can be a challenge. And, again, it's an area of focus for either, particularly because sutures that need to be put away, they're redundant, they're specialty sutures in different places, they're loose and expired. This again is an area, even if you started small, to understanding your preference cards, maybe there's sutures that are on those preference cards that need to come off those. But this is another area to capture cost savings. And then, bins to return products. And again, this speaks to preference cards. This speaks to, overall inventory management. But it is an area, again, maybe this isn't exactly like how your OR is, but, some of these items, these small items are worth hundreds, thousands of dollars, sometimes tens of thousands of dollars. And so, having this, awareness is so key. Having processes and, really just being focused on these initiatives, again, adds to, the value of having an optimized inventory. And, here are some recommendations as it relates to consignment. Consignment agreements are great. However, they're also a problem because many times the consigned inventory is mixed with your own inventory, or many times, there's not really good processes in place. And so, number one, most important, is to reset your consignment agreements. Go through all your consignment agreements, get them reset. Maybe you need to reduce those numbers, or have an audit review, or change the terms and conditions. But this is a big financial risk for hospitals, having a consignment that's not well defined or organized. And so, there's many different ways to do this, but really starts with resetting of those agreements and having that a go-forward policy in place, to manage.
So the next few are just some examples with, obviously, COVID, which has impacted a lot, and we've learned a lot over the last year and plus. But we've also seen a lot of where, just contracting better should have happened, and now we really need to move it forward. So perfusion services and clinical purchase service, many have these minimum monthly case volumes. We've seen clients where, they're paying even half of their monthly minimum is there's not even cases. Similar with nitric oxide, where the volumes have gone up, but there's these fixed costs. We do see it, it's not on here, with a lot of physician agreements where the fixed subsidies, they weren't adjusted with their the ratios and for the room, and you're still paying for those subsidies. Rebates and agreements, we mentioned it earlier, how more and more are pushing back on rebates, but more vendors are that's their negotiation strategy to maintain their market share. But when the volumes are decreased based on obviously things like COVID and others, the rebates are not there. They're not hitting the terms and the volumes that were agreed upon. So paying a lot higher pricing based on these rebate agreements. These disposable equipment rentals now. The shortfalls, again, coming up at the end of these agreements, we're going to see a lot where, there's going to be these big payments that are going to be owed because of the shortfalls. We're seeing it now a lot in the lab, and it's going to be the same with a lot of the OR disposable equipment that's tied to equipment, or disposables tied to equipment. And then, the pharmacy distribution, med-surg distribution, a lot of you might not be involved in that, but the conversation should start to be happening because, again, it's all volume-based, and these contracts are going to be, geared towards, what was your last 12 months or 24 months, and then COVID, that means your cost minus is going to go down, and similar to the cost plus. Other ones that, just keep an eye on is these mobile MRIs, evaluations on site. We did a recent one with a client that, it was 3 days a week, but the data only supported 2 days a week. Just removing that 1 day a week reduced their cost by a third, or $200,000 annually. Maintenance, full service, right? Analyzing, especially there's a lot in the OR, analyzing really what is the primary, and then what is these secondary units. Do you need 24/7 on all of these? Is the gold plan on others, right? Does it have to be that much? Or can you go 9 to 9 Monday through Friday? So there's these things that you need to think about, that are in your budget, and a lot of them are fixed.
So we have about another 10 minutes left of our deck, and we're going to leave about 7 minutes for questions. So we're going to go through these relatively quickly, and again, you're welcome to email me to get the deck. So there's these 10 approaches that we talk about quite a bit. The zero-based budgeting approach, which is really to say start from zero and ground up, and to justify your supply item or service is needed. It is a time-consuming process, and but if you do this approach, it is a transformational approach to really budgeting and being able to say, do we really need this? 2, The industry talks a lot about clinical operations improvement and utilization improvement. It's very important. So I mentioned outcomes before. We're absolutely in agreement that we've got to measure cost with outcomes and quality and map those all together. Pricing is absolutely important. There are still a tremendous amount of pricing opportunities that have yet to be achieved. Supply chain excellence. We love building and supporting internal supply chain departments. It is key to have a strong internal supply chain department that that can perform spend analytics, negotiations to get benchmarking insights. We think that more investment should be made into your supply chain department. And as we saw during COVID, and we might be seeing further, that we have to be self-reliant. It is absolutely important. Cost awareness, having employee training programs about cost, physician awareness is key. Continually, cost improvement through innovation, data accuracy, that's your charge master, your item master, those have to be accurate because everything, it will be mapped back to that in terms of reimbursement or having, missing charges or having the right price. We talked a lot about spend analytics. I think that is, an important topic as we move forward and really having a spend analytics capability in your hospital, a cost management system in place, and we always like the 4 Ps, and that's just have a process, a plan, have a firm project management system, and always measure performance. And I talked a little bit about, zero-based budgeting before and about the ORs, and so only thing I will say a little bit more about pricing matters is that hospitals can't charge more. And so the fact that that's in place, it really is a driver to make sure that we are optimizing every single cost opportunity. And like Rich said, if you've got a contract that says a 3-day service and yet you can move that to 2 days, that's a huge cost savings. I mean, we really have to look at things creatively. And really understand our agreements. I think the one area that I think is so important is that within the OR, not only should you have an abstract or an idea of what those managed contracts are, but even on your contracts, there should be some form of contract summary that you can look to be able to spot check or review. It's, and located in one place, and to be able to understand and look at the terms for accuracy. And so this is an interesting study from JAMA. This was a study just based on cost visibility, essentially, giving physicians, surgeons a scorecard of the supplies they use in the operating room. That's all that was done. So one group showed the group that saw their cost, line item detailed cost, decreased their cost by 6.5%. Nothing else was done. There was just the visibility into a specific line item cost. Versus the control group, who didn't have any visibility, their group increased their cost by 7.42%. So just showing line item cost had this 14% opportunity or this variance of either reduction or increase. And we work with hospitals and really getting those physician scorecards out, and that's the basis then to have a level 2, which a level 2 is variation. Level 2, you can go so much deeper. But if you want to start on a physician cost awareness program, just start with just showing them and not asking them to do anything. We think this is the beginning of some great conversations you'll have. I just want to mention this very quickly. We talk about cost innovation. This was a hospital that had they outsourced their SPD department, and we worked with them to insource it. It was very relevant at one time for them to outsource. It made a whole lot of sense, but it had been growing and growing. And in fact, this 1 year that we were working with them, it was poised to have a significant increase. And they finally, we were talking with them, and they really said, I think it's time to bring it in-house. So sometimes we don't always think about insourcing things that are outsourced, but that's for those who have large outsource programs in the OR, maybe it's time to look at insourcing some of those, and of course always vice versa. And we talked about these. Again, spend analytics is so key, kind of having this view on, in this example, it's savings and spend by spine construct. And Rich is going to go over a couple of slides, and then I'm going to end, and we'll open it up for questions.
Great. Thank you, Lisa. And back to, obviously, spend analytics. This is really diving into the physician comparison, the different DRGs, blinded, obviously, we have the physicians' names, but we do this side-by-side case analysis to show them, where they line up with their peers. Then we do a deep dive, and we've done this where a specific physician, so this is physician-specific, and their payer mix, and what do they look like over a 12-month period, and really kind of understand, are they costs towards reimbursement, and we always want to get, the cost 30% total versus total in payments. That's a good starting point to work off of. And then also just understand any charge capture issue. This is a second physician, again, just showing the different areas that, we review. And then we break down into this, this is, again, based on the physician, what is the total, again, side-by-side, Medicare payer. This is the DRG 460 analysis. So just really diving into and making sure that they're cost aware is not only the cost, but also the reimbursement side as well.
And, these kind of mapping cost to reimbursement gives you the opportunity to have different conversations, because we had a question come in, and I'm going to start infusing some of these questions with the remaining slides. How do you account vendor value beyond the implant device itself, such as case support and education? How we define that as is that's part of their job, right? The vendors have a responsibility, to provide case support and education. Again, I'll go back to, hospitals can't charge more, and they have to look at their OR profitability to this kind of level of detail, because they, need to understand those variations. Vendor, there's a lot of value, but that value in terms of support and education can't be so much so that these case costs are upside down. I know that, the vendors care enough to want the hospitals to also be profitable, to serve their communities and to serve patients. So there has to be this balance of what is value that truly is monetized, or just the value that comes with, that the hospitals are paying and utilizing their services. So this is interesting. We've recently started to incorporate a number of different additional components into scorecards for physicians and even social determinants of health. Someone asked earlier how we measure quality, length of stay, and this is an example. This is unique to VI in how we put together quality, outcomes, assessment, social determinants, and experience. And so, we do believe in quality. We believe in outcomes. We believe in the patient experience, and incorporating all these things into cost. And so, this webinar was primarily focused on hospitals optimizing and getting this, to $1 million savings, to getting to profitability. But please don't think, we don't value outcomes. Outcomes are key and so important, and visibility into outcomes and metrics are very important. And I am going to give this slide to Rich, and then I'm going to answer some of these questions.
Right. And just again, real quick, just understanding the big picture, right? What is missing, and working with the health system, had a proposal, third party did an RFP, and we were working directly with the CIO. And the quote was sent to us. It was a big discount, but what was missed is really the question, and really what it was two big areas: professional services and the maintenance. And really, what ends up happening is, we were able to work with the CIO team and with the end users and be able to reduce the cost by an additional $1 million.
So as we wrap up, I want to talk to you about negotiations, then answer some of your questions. Negotiations is key. If you do Google, and we can give you some Google recommendations, you'll see a lot of companies that sell to vendors to teach them how to negotiate. And we say the hospitals have to be skilled negotiators too, skilled influencers, as they combat negotiations. And so there's a couple of things, and we'll talk quickly about. Remember, again, the vendors are skilled negotiators too. You need to create a strategy for every negotiation. You must, we have a nice framework we use. You can email me, I'll provide that framework for you. Having a negotiation buddy is key. 2 people in negotiation is so important. Use your higher authority. You have VPs, CFOs, get them involved. Time. Don't let these time frames go out 30, 60, 90 days. There's no reason why you can't turn over an agreement in 2 or 3 weeks. If you were to want a new service, you would get that new service in 2 or 3 weeks. So the reset on the agreement should also equally be in those 2 or 3 weeks. RFIs are a great way to get information, and a big underutilized approach is QBRs. Quarterly business reviews are key. There is a framework, again, we use for quarterly business reviews. You can reach out to me for that. And our approach is always a small, agile team of cross-functional hospital employees, which includes finance, supply chain, performance improvement, different department leaders, nursing, and physician champions. Seems like a lot, but there, again, is a framework to utilize their time in a you don't need a lot of time, but there's a way to strategically do this to get their input. You get your team together, you're going to have amazing results. And I am going to wrap this up a little bit, but to speak about, again, the spend analytics quality that's so important. It's forensic line item historical analysis. It's a detailed contract review. It's categorizing and benchmarking, putting together a complete cost savings opportunity in that contract negotiation. Somebody asked, Katie asked, how do you get detailed data? Is it collected manually or are you using a software program? That's a little bit of both. You do need data from your own systems, whether it's finance or your ERP system, but some of it is manual. And we have a tool that helps get that manual data together. But it is key to have those bill-onlys, and unfortunately, that would be a manual approach. I had another question about surgeons and preferences, which negate the ability to use different implant manufacturers. How do you navigate this from cost to quality? We want surgeons to have preference, and the first line of defense on that is, the playing field should be even. The pricing should be the same if it's the same product. So give physicians what they want. They just have to be able to have this all-play model that it is the same price. If you want to go down to that next level, which is standardization, it really is about data. But you have to have a foundation to be giving your physicians data. And then, getting to that next stage of standardization is going to require more information. They've got to trust your data. They've got to trust the approach. And yes, there probably are some situations where you're not going to make a physician change, and that's okay. But then get them on board to say, why pay more? Okay, we agree. We want you to have what you want, but here's some data. Here's some benchmarking. Here's 4 different insights for data. Can you help us at least get to the best price? And we're seeing surgeons get on board with that more and more. And I'm just going to jump to, again, we really appreciate you attending the webinar. This is my email, Rich's email, and I believe we answered most of those questions throughout the presentation. And if anyone has any more, I think we have 2 minutes, but I'm going to turn it back over to Carrie. You're always welcome to reach out to me. I would love to answer your questions. So thank you, everyone, for attending.
Thank you, Lisa, and thank you, Rich, very much for that great presentation, very robust. And I know we got in a lot of questions, so we'll start the Q&A chat now. Just want to remind everyone to submit your questions in the Q&A tab section on your screen, and your questions are only visible to the presenters. And so with that, I will get started with the first question. How important is price benchmarking our supply and high cost implant costs on an annual basis?
Yeah, that's a great question. Thank you. So many times hospitals are benchmarking upon renewal. High-performing hospitals, we believe in getting benchmarking on a semi-annual basis, at least an annual basis. You're going to see market shifts, and we think it's key to be in this mode of looking at the marketplace at least annually, but even biannually, looking at it twice a year. You could pick up some nice wins. And listen, a lot of these cost-saving wins are going to happen in different areas, and it's a matter of, always looking, having a continuous view of the marketplace. But it's a great question. Thank you.
Excellent. Okay, the next one. Time in the OR is one of the biggest expense when we look at the contribution margin per case. How do you analyze this and drive improvement in a teaching institution where residents need autonomy?
Yes, and so I addressed that a little earlier before, but I think the key is pulling out that data, getting the data consistently to the residents and having conversations. Listen, I think being comfortable with having conversations around time, but more equally as important, are you being consistent? I think one of the things that I see that they're challenged most with is that we kind of are giving physicians data sometimes, like every other month or once a quarter. But if you're consistently having the data accessible and given to physicians and sitting down and having just really normal, real conversations, just saying, look, there's a variation. Can you talk to me about maybe why that one case lasted 30 minutes longer? Or it seems like there's some opportunity. Can we do something better to support you? Remember, this is a team effort. So I think it's really having the data and having conversations.
Okay. And what is the best way to capture data analytics that can drive efficiency or operational savings?
So the best way to do that is to really understand where your data sources are from. There's never going to be one single source of data, so you're probably going to have 3 or 4 different sources of data. So it's a matter of knowing where you can pull the data and making sure you get that every single month, and being able to put it in a framework that it's easy. So for instance, we utilize Microsoft Power BI, which is great. It's a combination of Excel, Access, and it has some great graphic capabilities too. But once you script the data and you pull it together, every single month after, you're just pulling the data. But you need to know where your data comes from, and you need to also validate that it's accurate. So there might be a data cleanse process.
Okay. What action do you take with your monthly waste reports?
And we talked a little bit about, you saw some of those pictures and saw some of the waste. Again, with that monthly waste reports, how are you having the conversation? Sometimes it's a matter of just, maybe putting in a simple PowerPoint deck or a Word doc, handing it out, having time for those conversations. I think I think it's really, it's creating a process where you can have the visibility and support change and have ideas, but be consistent with that, and then follow up and make, even little improvements over time has massive, implications.
Okay. And then we just have time for just 1 or 2 more questions. Do you see preference card hygiene as part of this supply cost savings opportunity, or are they unrelated?
I think they're absolutely related. Preference card hygiene is absolutely related. It's essential. It's very important.
Okay. And I think this will be our last question as we're nearing the end of the hour. We have proven to increase OR efficiencies by 15 to 30% in certain extremity cases by eliminating OR skin prep. How valuable is that time savings? We are new to the market and are not sure if the time savings translates to money savings, even if more cases billed per week is possible.
Yeah, it's a great question. So I think the answer to that is those minutes matter, right? They matter as you optimize your surgery time. Those minutes matter, and putting additional cases matters, and also the profitability of those cases. So, having those time wins and turning over cases and putting more cases in, matters, and it also matters for physician satisfaction. If they can have more time, that's a financial win for the organization as well. So.
Excellent. Well, thank you, Lisa, and thank you, Rich. And I just want to remind the attendees that today's webinar has been recorded. Please allow about 24 hours to receive your CE quiz and certificate in your OR Manager account. I'd like to thank our sponsor, Vi Healthcare, and thank you all for attending, and have a wonderful day.